And today's topic of the discussion is about the classification and the clinical features of diabetes mellitus. So this has been very frequently asked, whether it be general medicine, general surgery, pathology, even in the pharmacy and medical and dental students. Most frequently, you are supposed to write about in questions they can ask you, or even in the competitive exams, they can there are myriads of questions which can be asked about diabetes, the clinical features, and the particularly the classification of diabetes. So this is very very important, and today I'll be discussing as to what it is about, and I'll try to make it simple and easy for your convenience to understand as to what are the types of the diabetes, that is the type 1 and the type 2 diabetes mellitus. So students, beginning with, firstly, a one-line definition of diabetes mellitus, that diabetes mellitus, it is a metabolic disorder. So metabolic disorder means, word to word we'll get into it. What is a metabolic disorder? So a metabolic disorder is that disorder what is going to affect the metabolism, what it is going to affect the sum total of the chemical reactions what are occurring in the at the cellular level or at the body structure. So metabolic disorders are those disorders which are metabolism, the word itself is suggesting that it is the variety of chemical reactions what are occurring at the cellular level and at the body tissue level. So this diabetes mellitus, it is a metabolic disorder which is characterized by hyperglycemia. So diabetes mellitus, the word mellitus, it comes from that it is somewhat referring to something sweet. So diabetes mellitus, it means the condition is causing somewhat sweetness or hyperglycemia. So hyperglycemia means the blood glucose level is elevated, and this elevation of the blood glucose level is due to the absolute or the relative deficiency of insulin. So as you all might be very well aware that the important structure, the structure what is responsible for the production of insulin, it is the beta cells of the pancreas. So you all might be very well aware that the pancreas is composed of two things. First, it is the beta cells, the alpha cells and the delta cells, that is the pancreatic acini, and the next part, it is the cells what are present in it. So the pancreas, it is both, it is containing an exocrine part whereas the endocrine part. So the exocrine part lies on the periphery, whereas the sorry, the endocrine part, it is chiefly comprising of the cells what are going to lie in the center. So the endocrine part of the pancreas, which is chiefly comprising of the alpha cells, the beta cells, and the delta cells, so they are going to produce particular hormones. The alpha cells, they produce glucagon, the beta cells, they produce insulin, and the delta cells, they produce the somatostatin. So it is the endocrine part of the pancreas, particularly the beta cells, what are responsible for the production of insulin. Now, there can be an absolute deficiency of insulin, or there can be a relative deficiency of insulin. So what is the literal meaning of these two things? So getting into the trying to understand this, that what is absolute deficiency of insulin. So absolute deficiency of insulin, it mostly occurs when the pancreas is unable to synthesize, the pancreas is absolutely not able to synthesize insulin. All right. So if the pancreas is absolutely incapable of synthesizing or producing insulin, the pancreatic cells, they are no more or no longer insulin is being produced by them, or if it is produced also, it is in a very scarce amount. It is in a very less amount. So that is called as the absolute deficiency of insulin. Whereas the relative deficiency, what is the meaning of relative deficiency of insulin? So relative deficiency, it refers to that insulin is being produced by the pancreas, but the insulin what is being produced, the host, the individual has become resistant towards insulin. Means the quantity of the insulin what is being produced, that is not capable enough to uh, convert the glucose uh, into glycogen and store it in the body tissues or in the liver. All right. So absolute deficiency, when the pancreas is absolutely incapable of synthesizing insulin, and relative deficiency, it refers to that insulin is being produced by the pancreas, but the quality of the insulin what is being produced, that is not well capable enough for the ingestion, for the uptake of glucose by the cells. That insulin is not able to mediate the uptake of the glucose from the bloodstream into the cells. All right. So uh, now looking at what is the classification. So classification of diabetes mellitus can be it has been broadly divided into two, that is the type 1 diabetes mellitus and the type 2 diabetes mellitus. So type 1 diabetes mellitus, it is also called as the insulin dependent diabetes mellitus. All right. Whereas the type 2 diabetes mellitus, it is called as the non-insulin dependent diabetes mellitus. In a general or in medical terminology, we mostly call it as insulin dependent diabetes mellitus, as IDDM. That is IDDM, insulin dependent diabetes mellitus. Whereas in type 2 diabetes mellitus, which is also called as the non-insulin diabetes mellitus, it has been sometimes in short form, we call it as NIDM. All right. So this insulin dependent and non-insulin diabetes mellitus, these are the two types, that is the type 1 and type 2. Now, before getting into the deep discussion and getting into the differences between these two, what happens is we should try to understand one basic concept, that whenever the blood glucose level rises, whenever after a good rich carbohydrate meal, whenever after a rich meal, the blood glucose level is going to shoot up. So what is going to happen is this insulin, it is somewhat resembling to a key. A key for what? If a cell is there, excuse me, if this is a body cell, and if excess of glucose is being circulated in the bloodstream, excess of glucose is present in the bloodstream. Now what is going to happen is this insulin is going to act as a key. Just as a key is there to open a lock, similarly this insulin is going to act as a key for the transportation of the excess of glucose from the bloodstream into the body tissues, the cells of the body tissues. All right. So this insulin is going to act as a key. All right. So for the uptake of glucose by the body cells, this key insulin has to be present. If this key is being less produced, or if it is not produced, so if there is little or no insulin production, as in type 1 diabetes mellitus, so ultimately there is as such no key for the body cells to uptake this excess of glucose. So in type 1 diabetes mellitus, what is there is that the key is not being formed, that the key is not being produced by the pancreatic SNI. Okay, thank you. So this key is not being formed. Whereas in type 2 diabetes mellitus, so what is going to happen is that in type 2 diabetes mellitus, what do we see is that insulin is being produced by the pancreatic cells, but that insulin is not capable enough, that insulin is not efficient enough for the uptake of the glucose by the cells. Good morning. So for the uptake of the glucose into the body cells, that insulin is not capable enough. It is not that capable to make the transport of glucose into the cell. So if this is related to the insulin is the key, so in case of type 1 diabetes mellitus, the key is deficient, the keys are missing, the keys are not being formed if insulin is the key for the transportation of glucose into the cell. But in case of type 2 diabetes mellitus, if the insulin if it is the key which is responsible for the transportation of glucose into the body cell, so in case of type 2 diabetes mellitus, the key what is being formed, it is defective, it is malformed, it is a broken key, you can assume it as. So again, the unlocking of the cell and the transport of the glucose from the bloodstream into the cell won't be taking place. All right. So this is about type 1 and type 2 diabetes mellitus. What is the this was the basic concept what we need to understand before getting into the actual differences between. All right. So insulin is that key what is responsible for the uptake of glucose from the bloodstream into the body cells. If that key is not being produced, it is type 1. If that key is defective, it is having some kind of deformity. If it is a broken key, that if an insulin or what is being produced that is not capable enough of making the glucose transportation into the cell, then it is type 2 diabetes mellitus. All right. Now, starting with the differences. So, looking at the differences, that first thing that is the type 1 diabetes mellitus, which is also called as the insulin dependent diabetes mellitus. So, the insulin dependent diabetes mellitus, what is there? It is mostly, the word itself is saying it is somewhat dependent on the insulin. Means the pancreatic SNI, the pancreatic cells of the pancreatic cells, they are either insulin is being produced by them in a very little amount, or the insulin is not at all being produced by them. All right. So, in cases of type 1 diabetes mellitus, the pancreatic cells, they are either producing no insulin or a very limited amount of insulin is being produced by them. And this type 1 diabetes mellitus, it is an autoimmune disease. Now, what is the concept of autoimmune disease? Now, what is going to happen is that our body has a natural immune mechanism by which it recognizes foreign bacteria and viruses. All right. Okay. I'm discussing the topics. You can have a look. After that, I'll zoom it on this zoom this whiteboard over here, and then okay. Thank you so much. So thank you. So if this, I'll zoom the video, zoom the whiteboard once I get over with the discussion. So the type 1 diabetes mellitus, it is also called as the autoimmune disease, and this autoimmune disease, what is being there? It is how to understand it, that our body has a natural defense mechanism to ward off foreign bacteria and viruses. And whenever our body encounters such a foreign pathogenic organism, it the immune system gets activated. Now, in cases of autoimmune diseases, there is some kind of a alteration in the body's immune mechanism that the body is unable to recognize. The body recognizes its own cells as foreign bodies. All right. So once the immune system starts responding in such a manner that it starts identifying its own cells as foreign bodies, it is unable to recognize between the self and the non-self. So even the own cells of the body, if it starts attacking it, then the disease, what is called as the autoimmune disease, that our body's immune system has a very clear picture. It can very easily recognize between the self cells and the non-self cells. That is, the cells what belong to the body, the immune system is going to does is the immune system is going to do no harm to that, our own body cells. But in cases of autoimmune diseases, the body's immune response acts in such a way that it starts attacking the normal body cells itself. Now, in cases of type 1 diabetes mellitus, the immune system is going to attack the pancreatic those cells. Okay, gestational diabetes I'm going to discuss. The diabetes what occurs during pregnancy, it is called as gestational diabetes. So during the autoimmune conditions, what is going to happen is, in cases of type 1 diabetes mellitus, our immune system starts attacking the pancreatic cells. Okay, the pancreatic cells, what are chiefly responsible for the production of insulin. In type 1 diabetes mellitus, our immune system is going to attack the pancreatic cells, what are responsible for the production of insulin. Now it starts destroying, it starts degenerating the pancreatic cells, the beta cells, what are responsible for the production of insulin. So it is an autoimmune condition where the body's immune system starts harming its own pancreatic cells, thereby leading to a deficient or no insulin production by the pancreas. So type 1 diabetes mellitus, it is an autoimmune disease condition, and mostly it is seen that in type 1 diabetes mellitus, since it is an autoimmune disorder, so various other autoimmune disorders have been closely associated with it. So there can be presence of, in such an individual, there can be presence of the Graves' disease. Certain the autoimmune conditions might be, other autoimmune conditions might be associated with type 1 diabetes mellitus. So other fact that the other fact what one needs to bear in mind is that type 1 diabetes mellitus, it is mostly seen in children or young adults. That is, mostly the age group is less than 30 years. All right. So most the onset of such a diabetes is mostly seen in children and in young adults who are less than 30 years of age, and that's why it has been also called as the juvenile onset diabetes mellitus. That is JODM, juvenile onset diabetes mellitus. Since it occurs in young individuals, that is mostly in children and in young adults below 30 years of age, it's an autoimmune condition with little or no insulin production. So this is also called as the juvenile onset diabetes mellitus. And looking at the symptoms, so the symptoms can be for duration symptoms. The symptoms may be manifested for weeks, or the in the patients the body type as to how the patients are going to look. So the patients are going to look into as they are mostly lean diabetics. All right. So they are very, these individuals are very lean diabetic individuals are there. Whereas, and death, if it, the in type 1 diabetes, if death is going to occur, so that's a very rapid or a vigorous procedure phenomena. In this procedure, rapid death of the individual is seen because there is absolute deficiency of insulin. Now, in such cases, you can also find, since it is an autoimmune condition, so auto antibodies might be present. The family history is absent because it is entirely an autoimmune phenomena. So there has to be no familial history behind it. And the mostly, if it is, if this the hypertension is to be considered, the history of hypertension. So mostly in type 1 diabetes mellitus, the history of hypertension is absent in such an individual. Now, moving on to the type 2 diabetes mellitus, that is the non-insulin dependent diabetes mellitus. It means that insulin is being produced by the pancreatic cells. It is getting into the bloodstream, but that insulin, what is being produced, is extremely incapable, inefficient in the transportation of glucose into the body cells. So, it is mostly the non-insulin dependent diabetes mellitus, and such a case where the insulin is incapable of transporting the glucose into the body cells. Such a condition is called as insulin resistance. Means the quality of the insulin what is being produced, it is not that well that the body has developed and resistant towards it. Whatever insulin is being produced by the body, the body's the body has developed a resistance towards it. The body is not responding towards the insulin produced. So that the type 2 diabetes mellitus, it is mostly, when looking at the etiology, the causative factor, it is mostly polygenic, multifactorial in origin. Disease involves genetic and environmental factor. So, when looking at the insulin resistance, there is one question that why this insulin resistance occurs. So, it is again a matter of great research. That research has been continuously going on. Might be they think that it is somewhat the genetic predisposition of an individual, the environmental factors associated, and to some extent the insulin resistance what is being developed in type 2 diabetes mellitus. It is mostly okay. It is mostly what is the insulin resistance, what is being developed, it is mostly because in some cases it has also been attributed to the sedentary lifestyle. What is the individuals now in the modern lifestyle, the sedentary lifestyle is somewhat responsible for insulin resistance. So the what are the just a question on live was there, that what is the cause of insulin resistance. So there have been there is extensive research going on, and it has been attributed either that due to certain genetic predisposition of an individual, that insulin resistance can be there. It can be either a genetic predisposition, it can be either environmental factors, or somewhere or the other, this insulin resistance is mostly seen because of the sedentary lifestyle, the sedentary modern lifestyle, where little exercise, no exercise, just continuously sitting for hours and end and working. So no workout, let sedentary lifestyle. So this can be a cause of insulin resistance in type 2 diabetes. When looking at the age, so that individuals what are being affected by type 2 diabetes mellitus, they are mostly more than 30 years of age, that it occurs. Okay, then can occur after 30 years of age, and the symptoms may manifest for months or years. And mostly in type 2 diabetes mellitus, what do we find is that in contrast to type 1, they were lean diabetics, but in case of type 2 diabetes mellitus, the individuals suffering from it, they are obese individuals. Now, moving on to the next important thing is that ketosis resistance. Now, what is ketosis? Ketosis is that phenomena what is mostly seen in type 2 diabetes, what is mostly seen in type 1 diabetes mellitus, that in certain cases when the body is incapable of producing energy, glucose, it is a source of energy. So if body cells are unable to take that glucose, so ultimately energy, the body needs energy for its functioning. So in such a case, there are, if the glucose is not present within the body cell, what is going to happen is glucose is not getting transported in type 1. So the body cells, they are lacking the glucose for their energy consumption. For the fuel of the body cells, they are the body cells, they are incapable of getting the body cells, they are incapable of they are in deficiency of insulin. So in cases of type 1 diabetes mellitus, the now the body cells, they will start taking another option, that they are going to utilize the body fats for the production of energy. So the body fats, if they are utilized, the body fats, if they are utilized for the production of energy, that leads to the production of ketone bodies, and that leads to ketoacidosis in blood. That is the acetoacetate, the beta hydroxybutyrate, the ketone bodies. So in cases of type 1 diabetes mellitus, when the body cells, they do not have the fuel, that is the glucose, if they are deprived of, so they will start utilizing other energy sources, that other energy sources, that is the lipids, the fats, they are going to utilize for their energy. And if fats are being utilized for energy, what is going to happen is that will ultimately lead to the production of energy along with the ketone bodies. So in type 1 diabetes mellitus, the individuals, they are more, that is called as ketosis prone. They are more ketosis prone, whereas in type 2 diabetes mellitus, the individuals, they are mostly ketosis resistant. Now, when looking at the lifespan of the individuals, in cases of type 1 diabetes mellitus, the individuals dies, the rapid death in absence of insulin occurs, and for most of the times in non-insulin dependent diabetes mellitus, the patient is going to live for many years. Now, since it is not an autoimmune condition, so autoantibodies are absent in type 2. And the family history, when looking at the family history, that we ask the patient that either your grandparents, your parents, were having diabetes or not. So in cases of type 2 diabetes mellitus, there is a positive family history of diabetes being run. So, and whereas the history of hypertension is also present in type 2 diabetes mellitus. So this was a very short discussion about the important, striking, differentiating, distinguishing features between type 1 and type 2 diabetes mellitus. Now looking at the clinical features. So clinical features, most of the patients who come to the OPD, most of the patients. Okay, okay, sure. So most of the symptoms, what are the clinical features? So such a patient who's having diabetes, mostly they complain of the polyuria. Means they have a frequency of running to for micturition very randomly. Mostly they go and they keep on running to the washroom. They feel the urge for frequent micturition. So this is a very important fact. What one should keep in mind, if the urge of urination has increased, one might suspect that might be the person is having diabetes. So one should get it tested. One should get it tested, that if the frequency of urination has increased, one may get suspected about it. So there is polydipsia. So even the most frequent urination is there. The patient keeps on running for micturition, for urine discharge, and after that the patient is more or less more thirsty. So the condition, the medical terminology, this is called as the excessive thirst. It is called as polydipsia. So the patient is having the exhibits excessive thirst, and he keeps on drinking more and more water. Now, nocturia. The next clinical feature is that the patient keeps on running to the washroom at night also. He feels the urge of urinating at many times at night. He cannot have a sound sleep. So, rapid weight loss despite good appetite. The next clinical feature is that in cases of diabetes patients, the appetite of the patient is very good. But one thing what makes them suspected is that in spite of having a very good appetite, there is very rapid weight loss of the individual. So rapid weight loss is occurring. There is tiredness. The patient feels tired, lethargic. There is easy fatigability. The patient gets fatigued very easily. There is irritability. Blurring of vision is there. The patient is predisposed to frequent infections. And if it is a case of diabetes, since the blood glucose level is extremely elevated, it is uncontrolled. If it is an uncontrolled diabetes, the patient is going to show slow healing of wounds. Now, looking at the bacterial and fungal infections of the skin is very, very common. All right. So bacterial and fungal infections of the skin as well as the genitalia, they are the very important clinical features what are seen. And another important as to how we can, in males and females, what is going to be seen is that balanitis in males, whereas pruritic vulvae in females. This is another clinical feature what is being seen. Now, understanding what is balanitis in males. Now, in cases of diabetes, since the blood glucose level has risen, it is uncontrolled blood glucose level. So ultimately, glucose is being filtered in the urine. So what occurs in balanitis? That in balanitis, the male individual, when he is going to discharge urine, so on the um, anterior region of the penis, on the glans penis, what is going to happen is that if droplets of urine, they get trapped in between the foreskin. So since the urine is very rich in glucose, so that provides an ideal environment for the thriving of bacteria and yeast within the foreskin of the glans penis. So that causes balanitis in males, and that is also referred to as diabetic balanitis. Whereas in females, the same thing is happening, that urine, if it gets entrapped into the vulvae of the females, what is going to happen is that since the urine is very rich in glucose, so that urine is going to get entrapped within the vulvae, and that creates an ideal environment for the thriving or the survival of the pathogenic yeasts and bacteria and fungi. So that causes an itching feeling in females, that is the pruritic vulvae in females. And it has been also seen that in patients, in males who are suffering from diabetes mellitus, they exhibit some, in some individuals they may also exhibit erectile dysfunction. Okay, so it this nocturia is going to vary from person to person. That has not been that frequency will be set. It depends on the how much the diabetes is uncontrolled. So erectile dysfunctions are also seen. And one thing more, in both type 1 and type 2 diabetes mellitus, according to the American Diabetic Association has said that in cases of type 1 and type 2 diabetes mellitus, there can occur numbness and tingling. Numbness and tingling in the extremities, in the fingers and the toes. Numbness and the tingling is going to occur. So, if diabetes is controlled in such individuals, the management for this numbness and tingling is that is the control. The diabetes should be controlled. So, the American Diabetic Association has said that in both type 1 and type 2 diabetes mellitus, there another clinical feature what can be seen that the patient may complain of numbness and tingling within the fingertips and the palms and the toes. So this can be controlled, this can be managed if we have a good management of the blood glucose level. So students, this was a very short discussion about the clinical features, and I've tried my level best to simplify the classification, that is the type 1 and type 2 diabetes mellitus. If you still have any queries or comments, you're most welcome to comment me in the comment section. And students who are visiting my channel for the first time and they haven't subscribed yet, go do subscribe my channel, and don't forget to press the bell icon so that you can be further updated for my upcoming videos. Okay, I'm going to classify. The upcoming video of mine will be mostly I'll be dealing with the complications what are associated with type 1 and type 2 diabetes mellitus. So the next video, stay connected. I'll be talking of the complications, the acute and the chronic complications what are associated with diabetes mellitus. I'll be discussing them, I'll be classifying them. So students, if you have any queries, don't comment me in the comment section. And for the students who have not who want to have a clear view of the boards, the whiteboard notes what I have written, so I'll upload a picture in the upload section after the playlist. You can go and have a look of this picture, and for them I'm just focusing this whiteboard. You can have a look as to what all I have written. I will click a picture of it and will upload it in my playlist section. All right. So you can have the clinical features and the points what I have written. You can have a look by the picture what I will be uploading. Okay, sure. Okay. Thank you for watching.